This is not under the respiratory unit. This is under the vascular unit, right after DVTs. So you've had DVTs previously, right? Probably MedSurg 1. Okay, so now this is one of the consequences of a DVT, the life-threatening consequence. Nobody dies from a DVT. You die from a PE. Now, this is the obstruction of an artery by a clot. Does this sound familiar? Module 1, we had MI, correct? Yeah. And then we had stroke a few weeks ago, and that was caused by a clot also, correct? Yeah. Right. So both of those prior conditions were caused by a clot. Did the heart muscles die in a MI? Yes. Yes. Did brain cells die after stroke? Yes. Yes. Okay. So here, why doesn't the lungs die? Why doesn't the lung die after a PE? Well, when they have a PE?
Because they have multiple different areas of oxygenation.
Well, what about the area that is supplied by that artery? Doesn't that die?
Yeah.
So should not this be called a pulmonary infarction? Yeah. It's not though. They call it pulmonary embolism. Why? Let's say we can have multiple too, because we can have a massive PE. There are 3 categories of a PE. We have mild, we have, we have submassive, low risk PE, we have submassive and massive PE. A massive PE will see multiple number of clots, multiple branches of the pulmonary arteries obstructed, and large clots as well. That's a massive PE. Patient will die not from a PE, but from obstructive shock. The patient will die from shock with a massive PE. They go into cardiac arrest. So why isn't this called pulmonary infarction? To answer the question, do you remember, let's go back to Dr. Farrington. What trivia question did he ask you? Which is probably, which artery is the only artery that carries deoxygenated blood? Which vein is the only vein that carries oxygenated blood? Pulmonary vein. Okay, so therefore, the pulmonary artery, what kind of blood is it carrying? Deoxygenated blood. Is this bright red or dark red? This is dark red blood that it's carrying. It has no oxygen. It's going to the lungs to get oxygen and then returns to the heart via the pulmonary veins already carrying oxygen. So therefore, is this artery or these arteries, because there are several branches of the pulmonary arteries, do they really perfuse the lungs? Do they give oxygen to the lung tissue? No. No, because they're not carrying oxygen. They're going to the lungs to get oxygen, correct? Mm-hmm. So therefore, which artery supplies blood and oxygen to the lung tissue if it's not the pulmonary arteries? Where does it get its blood supply? Because lung tissue need blood and oxygen too. The bronchial arteries. Okay, so the bronchial arteries do not come from the pulmonary artery. They come out of the descending aorta. So if you look at the descending aorta, right after the arc and then descending aorta, the first branches there are 2 bronchial arteries. Those arteries supply blood and oxygen to the lung tissue. Clear? Now, does pulmonary infarction ever happen? Yes, it can happen, but extremely rare. I mean, it's almost, I can confidently say it's almost impossible to infarct lung tissue, but it's very common to get a pulmonary embolism down. Okay, so we understand what the nature here is. Okay, so the problem here is no oxygen to the rest of the body because the very arteries that go to the lungs to get oxygen, can they get oxygen and return to the heart? No. So since not all Not all pulmonary arteries are blocked though. So that's why we have three categories of pulmonary embolism. We have low risk, we have submassive, and then massive PE. We'll look at the manifestations because it will be different for each one. Let's look at the pathophysiology. So how did these clots get there? Where do they come from? Remember the three conditions again that we form a clot? What are those three conditions? Now, our body forms clots when? Okay, so that's one. Okay, so go up in the same chapter under the DVT chapter, DVT section. Okay, so we have the Virchow triad, which are one, you said, venous stasis. What are the other two? So venous stasis means there's the blood is not moving. Blood is stuck somewhere right here. This is the second one. What's the first one? Endothelial injury, direct trauma to the arteries, just not the veins, arteries, capillaries, any blood vessel. Okay, just look at that way. So endothelial damage is one. Any injury to a blood vessel. So when do our blood vessels get injured? When we sustain what? Is it just trauma? What about surgery? Okay, so when you have surgery, what about when you are menstruating, giving birth? All right, so those are all traumatic conditions, correct? So any injury to a blood vessel causes us to form clots. So that's what we're referring to endothelial damage. Venous stasis, so what conditions would cause blood to be stuck somewhere, not move, or move very slowly? Okay, immobility, any immobility condition. So does that include patients in the ICU?
Yes.
Patients after surgery? Old people? Okay, old debilitated people. Okay, so any bedridden people. So what about me? On weekends, my mobility decreases. Okay, I'm just on the couch, remote, and everything's handed to me. Does that cause venous stasis? Yes. Okay. And then finally, altered coagulation. Altered coagulation means any condition that will disrupt your blood, normal blood function. So let's say when you have DIC, is that a alteration in? Yes. What about in TTP? Yeah. ITP, right? So conditions or cancer, for instance, you saw cancer a few weeks ago. We did what were the six the first two again of the six oncologic emergencies? DIC and sepsis, right? Okay, so you saw sepsis already, how it leads to inappropriate clotting. Others are, let's say you're smoking, okay? Or let's say you take oral contraceptive pills, okay? Those form blood clots as well because they alter coagulation. Other conditions are, let's say you have a blood disorder. Okay? Usually, again, brings us back to cancer. So these are the conditions that lead to clot formation. We'll keep referring back to the DVT section because they did not repeat the treatment here. Because treatment for PE is the same as treatment for DVT, right? Same anticoagulants, or in this case, if it's massive PE, we may need to use thrombolytics. Right, any question on how PE forms? Can a PE also form from AFib?
Yes.
A-flutter? So which of the triad would you put AFib and A-flutter under? Venous stasis, endothelial injury, or altered coagulopathy? Stasis, because what happened in AFib and A-flutter? Now, are the atria really contracting? No, they're just quivering. So are they pushing blood anywhere? No, blood gets stuck in the atria, so that falls under venous stasis. So the patient's category of PE will depend on the size and number of the blood clots involved. So we don't know how many clots will form or how big they're going to be. So that will determine how many branches of the pulmonary arteries they will end up obstructing. So there will be consequences here, again, depending on the size and number of those blood clots. So let's look at the, how do we, let's go to the, let's just go down the list. Okay. So what happens in, so what if the pulmonary arteries are obstructed? So what? Why does it cause problems? Is there a balance between oxygenation and oxygen delivery? No. So that's what we call a ventilation perfusion mismatch or ventilation perfusion imbalance. Technically, is there anything wrong with the lung tissue in this condition? No, not at all. Lung tissues are fine. It's the gas exchange part that is affected because one or more of the pulmonary arteries, are there blood going into them if they are obstructed by blood clots? No. No. So that's where the problem comes. So there's no problem with oxygenation. The lungs are getting oxygen. However, can they get that oxygen into the blood vessels? No, because there's one or more pulmonary arteries obstructed. So there's an imbalance between ventilation and perfusion. It's perfectly fine with the ventilation part. It's the perfusion side that is problematic. You understand? Okay. So you'll understand this later also when we get to the testing, okay, to the diagnostic testing. Manifestations, they're not really specific here. They're non-specific, meaning there's no set of signs and symptoms that will say, oh, that's a PE, right? Unlike pericarditis, wherein you have signs. So this one, it can be anything. It could be a heart attack. If you put a PE patient and a heart attack and MI patient side by side, they look the same. They will both have chest pain. They'll have shortness of breath. They'll have low oxygen saturation. So we don't know which one based simply on the symptoms. So therefore, it's always diagnosed with blood tests and imaging. Okay. So the symptoms, again, non-specific. They'll have shortness of breath. They'll have chest pain. They'll have angina, because this can also trigger a what we call a demand ischemia, because is this a hypoxic condition? Yes, low oxygen delivery. So what happens to oxygen delivery to myocardial tissues? Decreases. So will that cause some of your myocardial cells to die? So will it elevate troponins? Yes. Yes. Okay. But this is not a heart attack though. It will just elevate troponin because of that result. So do you monitor it? Again, we don't know until we get the scans done. Okay, so until then, this will be treated as either, it could be ACS, it could be PE, we don't know. Okay, so the prime diagnostic test is in the diagnostic imaging. Okay, so we'll get to that. So other symptoms, again, anxiety, because is this scary? Yeah, you'll be scared to death here. You can't breathe. So these are the other manifestations: tachycardia as a result of hypoxia. There's feeling of impending doom. We call it apprehension. There's cough, diaphoresis, because there will be pulmonary edema here as well. So there will be some blood in the sputum. And of course, because depending on how many pulmonary arteries are blocked, what happens to forward blood flow? It's going to drop, right? So therefore, what happens to cardiac output here? It will also drop. So depending again on the severity or the category of the PE. So some PE, especially the massive, can cause shock, can cause cardiac arrest.
So what's the strategy
Yeah. Is this a hypoxic episode? So do you have enough oxygen circulating? So what happens to oxygen delivery to myocardial tissues into the coronary arteries? Okay, so it's not going to be as high though as an MI, right? There will be elevated troponin, but not definitely what I'm saying is we can't make a diagnosis simply based on blood tests. Okay, so here's now the prime diagnostic test. So we need to send the patient to a CAT scan. What's the problem with a CAT scan? Because what kind of CAT scan are we doing here? With or without contrast? There has to be contrast. Okay. So the purpose of a contrast is what? Why do we put in a dye? To see the pulmonary arteries. So we need to visualize what do the pulmonary arteries look like so that we can locate where the obstruction is. What's always a problem when we do a CAT scan with contrast? Kidney, right? Kidney issues. Okay, so let's say this patient has a kidney injury at the same time, which can happen because remember, oxygen is low. So can this cause pre-renal AKI? Yes. So let's say there is kidney injury. Can we do the CAT scan with contrast? No. So there's a alternative. We can do a VQ scan. What is a VQ scan? It is a nuclear medicine scan. So instead of injecting dye into the patient's IV, we will give them a radioactive gas to breathe. So when they inhale the radioactive gas and then you scan the lungs, will the gas enter the pulmonary circulation?
Yes.
Will it enter if there's a blockage of one or more pulmonary arteries? No. So that's the other way to do it. Instead of going through the vascular system, you will go to the pulmonary system. So you give them the radioactive gas, whichever part of the lung does not show the radioactive gas, there's the obstruction. You agree? Because otherwise, if it was well perfused, then the gas would appear on the lung tissue, right? So whichever parts of the lung tissue do not show the radioactive gas, there's the obstruction. So they can locate, that artery there is blocked, right? Because it's not showing the gas. Make sense? Yes.
Because it's a radioactive gas, does it linger?
No, it's very minute. It's short acting. I'm not saying completely harmless, but no, less damage compared to IV contrast. So some of you may say, why not just do that while it's expensive? Okay, so the cheaper scan is the CAT scan. VQ, or it's also called VQ, let's just call it VQ. It's ventilation quotient scan. So the technical name is ventilation perfusion scan. It should really say VP, but they don't call it VP. They call it VQ scan. Other testing, of course, will draw blood tests because we need to see other problems. Okay, let's say, is this a heart attack? Is this a heart failure? For heart failure, what blood test do we draw? BNP, very good. If it's a clotting thing, what do we draw to see if there is a clot? D-dimer, very good. So we'll draw all those. And if the D-dimer is high, so it's pointing more toward a clot, correct? So then they'll order either the CT with IV contrast or the VQ scan. All right. So once the diagnosis is made, okay, we start the therapy right away. Let's go to medical management now. Treatment will depend. Is this a low-risk PE? Is it a submassive or is it a massive PE? Yeah, massive PE is also called hemodynamically unstable PE. Okay. They usually go straight to the ICU because they're in cardiac arrest. If they are in cardiac arrest, what do we do? A, cardiac arrest. So, okay, BLS. All right, very good. So after, let's say they start with massive PE first. So we'll do BLS, CPR, and then ACLS drugs, which is beyond the scope of this textbook or this chapter. Let's go now to the pharmacologic treatment. Okay. If it's massive PE, that means the clot is so big or the number of clots is so large or numerous. So what can we do? Do we have time to, let me explain the, let's review the drugs again. Let's go back up under DVTs, table 26-2. Okay, let's review the therapy. So the treatment for DVT or PE can be anticoagulants or thrombolytic agents. Okay, so what's the difference between the two? Aren't they the same?
No.
Why not?
The thrombolytic agents break up clots.
And
Anticoagulants.
okay, so if let's say the doctor orders an anticoagulant and the patient has a PE, so you said what will anticoagulants do, Terry?
Stop it from forming a clot.
Stop new clots from forming, but there are already clots. Kamaji? Okay, prevents them from getting any bigger, all right? But there's still clots there.
So what did you have to give for?
Okay, no. Okay, depends on, again, how is the patient doing? Is the patient stable or not? So, if the patient is stable, meaning no hemodynamic problems, there's no signs of shock, vitals are okay, oxygenation is relatively all right with oxygen supplementation, we will only expect them to receive anticoagulants. If it's massive PE though, we have no choice. The doctor has to order thrombolytic in order to restore perfusion to the lung tissue so that cardiac output will improve. You follow so far? Okay, so thrombolytics, I mean, you understand the danger of thrombolytics, correct? We talked about this extensively in stroke and in ischemic and embolic and thrombotic stroke. So we know this drug is dangerous. So we don't throw around thrombolytics just to anybody. It has to be really necessary. So if the patient shows hemodynamic instability, then the doctor will choose to give thrombolytics to restore perfusion to the lung tissue. Otherwise, we will only give the patient anticoagulants. Okay. Because why? Why doesn't the doctor order thrombolytics for all PE patients since they have clots? Why don't we expect to give thrombolytics? It's a clot. What do you remember from your clotting cascade? So what happens after a fibrin clot is already formed? So I have a clot here. This is a blood clot. What happens after it is formed? What will the body do to it? As soon as a clot is formed, our body will start destroying that clot. It will start. That's why we have, where do you think the D-dimer came from? From the clot. So therefore, as soon as a clot is formed, the body will start breaking it down. So that's why when you have clots, your D-dimer will rise. Because where did that D-dimer come from? From those blood clots. Because our body is programmed to destroy a clot right away. How long does it take? That's the other question. Because depending on how many clots are we talking about? How big are those clots? So it will take days or weeks or months in order to dissolve that clot. But as long as the patient is hemodynamically stable, is there a need to dissolve the clot and risk by giving a thrombolytic and risk massive bleeding? No, not necessary. You understand? Okay, so anticoagulant therapy is enough just to keep those blood clots right now from getting any bigger, meaning we won't allow the body to make new clots, and they will stabilize those existing clots. Okay, so just allowing the body to dissolve them naturally. Clear? All right. So let's review. So you'll be tested again on all anticoagulants. So the usual therapy is, let's look at how they work so that you understand which ones are prescribed first. So let's start with heparin. There are two types of heparin. We have unfractionated, and then we have, what's the other type? Low molecular weight heparin. Okay. Unfractionated heparin is a thrombin inhibitor. Here, it's antithrombin. It inactivates clotting factors 12, 10A, and has a half-life of, look at the half-life, 1 to 1.5 hours only. Okay, so why is it given? This is its action. Prevents new clots from forming, prevents existing clots from getting bigger, or from existing clots from extending. Okay, any questions so far? No. Okay, so it can be given subcutaneously, intermittently, or continuous IV. For PE patients, they will be on continuous, what I should say, submassive and massive PE will receive continuous IV infusion of heparin. Okay. Now look at the half-life. Since it's only 60 to 90 minutes, do we need frequent or infrequent checking of the PTT? Frequent. That's the reason for every 6-hour PTT monitoring. So every 6 hours, phlebotomist has to come up, draw blood for PTT, and then repeat every 6 hours. Why again? The half-life is only 60 to 90 minutes. So if this is the case, why use heparin? It's very short-acting. Why use this one? Well, if you look at also how it acts, it's a direct thrombin inhibitor. If you don't know what I'm talking about, maybe this will help. So let's just 2 minutes. Let's review the cascade. So how does our body form a blood clot?
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway.
So we're only looking, right now we're still looking at the clotting, okay? This doesn't talk about any of the anticoagulants. So what you're looking at is a injured blood vessel. This could be a capillary. And these things that are attaching to this are the platelets. So this is showing the extrinsic pathway. Takes just 1 second or less. Platelets will stick to the broken surface. What do we call this part of the Velcro triad again? Endothelial injury. So endothelial injury happened, platelets gather and cover the injury. This will stop the bleeding like this. However, is it a stable hemostasis? No, because the platelets simply adhered to it. Can this be dislodged? Yes. Yes. You move or you wash your hands, this will bleed again. Okay. But it will work as early as 1 second. Okay, so a few seconds, the bleeding will stop. However, since it's not a stable clot, you notice after you get a paper cut, if you move it or you touch the wound, does it bleed again? Yes, because you disturb the platelet plug. Okay.
Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor.
Okay, so after the platelets formed a plug, no, they stuck together, they stuck, and then they covered the injury. So the injured blood vessel will next produce this thing. This thing was the same in the cases of cancer. Why cancers cause blood clots is some cancer cells produce this. They produce and release tissue factor, which of course triggers clotting. So that's why some forms of cancer will have blood clots. because cancer cells produce it.
which forms a complex with factor 7. Finally leading to the activation of factor 10.
Okay, so this is now the intrinsic pathway. So this will lead to the fibrin clot formation, the permanent stable clot. So starts from tissue factor and then activation of your platelets, clotting factor, sorry.
This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet.
Okay, so extrinsic pathway involves what parts of your hemostasis again? Only platelets, okay? So extrinsic pathway, only platelets. The intrinsic pathway, which takes a few minutes, involves all clotting factors. You see why it takes long, because look at the number of activations. So we saw factor 7 and then factor 10, and then we have 10A.
The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction.
Okay, so this is where, when we get to the table again later, warfarin, which is Coumadin, correct? Coumadin or warfarin is a vitamin K inhibitor. Now, there's no mention of vitamin K here, but these clotting factors enumerated here are vitamin K dependent. So therefore, if you take a drug that inhibits vitamin K synthesis, can you make these 4 clotting factors? No. So can this lead to a clot?
Yes.
No, if you don't have these, can you make a clot?
No.
No. So this is where warfarin comes in. So when you take warfarin, this is how warfarin works. It eliminates these 4 clotting factors. So therefore, none of these are available. So can you get the clotting? No, it's impossible.
At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the 2 pathways merge at the level of factor 10...
Okay, so this is now 10A. So you saw 10A in the extrinsic pathway. We saw 10A here in the intrinsic pathway. So therefore, when you take 10A inhibitors, so these are the drugs that are rivaroxaban, apixaban, those novel oral anticoagulants. No, the PO, other than warfarin. So this is where they work. So they inhibit the formation of factor 10A. So without factor 10A, can the clotting cascade continue? No, because this is the pivotal point. This is the central point wherein the fibrin will be activate the formation of fibrin.
This factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst.
Okay, so this is where heparin comes in. Heparin is a thrombin inhibitor. So heparin will stop this from happening. So see what happens if you take heparin or give the patient heparin.
1 molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin.
So this will not happen. So if you give the patient heparin, regardless if it's unfractionated heparin or low molecular weight heparin, this will not happen. So therefore, can thrombin or fibrin be created? No.
These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
Okay, so long story short, after this event happens, so after a clot is formed, this is now held together by fibrin, right? So the body will start breaking it down. And what remains of fibrin after it's destroyed is called D-dimer. Any questions up to this point? All right, so let's go back here. Any question on how heparin works? So therefore, does heparin take time or immediately to work? It works immediately. So that's why, which is the first choice? Heparin first. Can we send the patient home on heparin though? That's the problem. So we will only put the patient on heparin in the hospital. but does it provide immediate anticoagulation? Yes. Look at the half-life, only 60 to 90 minutes though. So is it also a good choice? So let's say this patient will require surgery. Can we use heparin?
No.
No, they need surgery, but they also need anticoagulation. Can we use this? Look at the half-life, only 60 to 90 minutes. Can I stop it 1 hour before surgery and then cut them? Yes. Okay, so very good choice, right? You understand? I mean, any question? Why it's safe for a patient? Meaning, when I put you on anticoagulation, did I do that just for fun? No, there's a reason for it, right? Because you're at risk for clots. You're, let's say, high risk for stroke, a PE, whatever. That's why I'm giving you heparin. I'm giving you an anticoagulant. But you also need surgery. How can you reconcile that now? I need to keep you from clotting, but then you need surgery. You understand? So therefore, do I put them on an oral or this? I'll put them on this because the other drugs have a longer half-life. Okay, so it's easier to control with heparin. All right. So we put them on this first, but because I can't send them home on it, so what will I start them on the same day? I will put them on an oral anticoagulant as well. Low molecular weight heparin because this has a 12-hour half-life. So can I use this if a patient is pre-op? Not a good choice. So this one would usually be prescribed for patients with low risk PE. No tiny clots with little to no symptoms. They can be safely sent home on
that medication, and they have to open how many days before they
okay, so ask a good question. So if the patient, let's say, requires an elective surgery, so let's say we planned open heart surgery, right? Or heart transplant, whatever the surgical procedure is, and they need anticoagulants, correct? Will this be the best choice? No. So what usually will happen with those patients is, let's say your surgery is Monday. You will be advised to stay in the hospital to check in by Friday. So you need Friday, Saturday, Sunday to wean you off of whatever anticoagulants you're on and just keep you on heparin infusion. Just keep you on this. You understand the reason, right? Because this is easier to control, right? This gives you immediate anticoagulation, protecting you from blood clots until the very last hour that you're going to have surgery. Then we can stop it safely. And then you go to surgery. No, no risk for bleeding because this is already weaned off, right? And then start you right back after surgery. All right? Okay. Did I answer your question? So who's given low molecular weight heparins? Again, low risk PE, no asymptomatic or very little symptoms, stable hemodynamically. They can be put on Lovenox or dalteparin. I think is Fragmin. Yeah, I think it's Fragmin. And then because another thing about low molecular weight heparin is this is weight-based. The dosing is weight-based. So therefore, do we have drastic weight changes from day to day? You and me?
No.
Like, do we change weight
No.
by 10 pounds week after week?
No.
No. Pretty much it stays the same, right? You lose or gain 1 or 2 pounds every few days, right? So therefore, since the dose is based on your weight, and you agree with me that the weight doesn't really change drastically, is there a need to monitor PTT in these patients at home? Okay, let me go back here. The reason why we monitor PTT every 6 hours here is because the half-life is so short. So therefore, do I need to change the dose every 6 hours? Yes, because the half-life is very short. So it can be, it can change the dose every few hours, correct? Depending on how my body is metabolizing heparin. Here, since the dose is based on the weight, here, the dose for unfractionated heparin is based on the PTT. So as the PTT changes, the dose changes. Here, the dose is based on what?
Wait.
The weight. So do I need to monitor the PTT?
No.
No, because the dose is based on the weight. So unless the patient really has drastic changes in the weight, then otherwise, no need to monitor PTT. Vitamin K antagonist. So this is warfarin now. So depending on what oral anticoagulant will the doctor send the patient home with? Well, that wasn't a question. So I'm telling you that whatever the doctor decides or whatever the patient needs will depend, that will be what will determine the therapy. So let's say the patient will go on warfarin. Then the patient will be on heparin first, and on the same day be given warfarin. So let's look at why. Why is the patient on both heparin and warfarin at the same time for a few days? Okay, so how does warfarin work again? Vitamin K antagonist. So when I take it today, what will happen to my vitamin K production? Inhibits. It's inhibited. So will I still be making normal amounts of vitamin K? No. So therefore, am I making enough clotting factors? No. Those 4 clotting factors? No. So factors 2, 7, 9, 10. Am I making these today? No, not today, right? I take it today, it will stop production, or it will slow down production. However, there are already clotting factors in my body, in my plasma, already made yesterday or a few minutes before I took warfarin. So what will happen to those? They're already in the plasma. Will they be affected by warfarin? No, because warfarin will only affect future production of clotting factors. So therefore, will warfarin work today? No. We will have to wait until my body gets rid of the existing clotting factors already in my plasma. So therefore, will this take effect today? This will take days before we reach a INR of 1.5 to 2 times the normal. So our INR goal for PE, first time PE, I just have PE today, will be 2 to 3. This will take, it will depend. Some patients are okay. They reach this by the 3rd day. Some patients will reach it 5th day, some 1 week, some maybe longer than that. We don't know. Until then, we draw INR, PT-INR every day until we reach 2 to 3. So once I hit the goal, what happens to heparin? I don't need heparin anymore. I've reached my goal. But until then, the patient will continue receiving heparin and warfarin at the same time. Why again? Okay, the warfarin hasn't done its job yet. It's still taking time. Meanwhile, what's my heparin doing? It's protecting me today. Okay, it's been protecting me since the first time you started infusing it. Clear? Yes. So the heparin gives you immediate anticoagulation. The problem is, can I go home on heparin? No. No, because who's going to monitor PTT? Okay. And you already know about the antidote, right? Vitamin K? Yeah. Okay, so what are those foods again? Okay, so it's somewhere in this chapter, so please read. Let's go now to the, what's the antidote for heparin?
Sulfate.
Very good, children. The rest of these, the other oral anticoagulants are factor 10A inhibitors. So fondaparinux, rivaroxaban, apixaban, edoxaban, betrixaban, they're all oral anticoagulants. So fixed dose, no, as you can see here, no, do they have any blood monitoring on the last column, fourth column? Do you see any there? Nope. No monitoring, right? No PTT, no PT-INR. Do you see any diet restriction? No diet restrictions. Okay. So if the patient is a candidate for these, then the better for them. All right. And last, which is very rare, where did you hear argatroban again? Remember last semester you were presenting, one group was presenting argatroban. You remember what this is? Okay, so if the patient has HIT, then can we use heparin? No, but they need anticoagulation. What do we use instead? Argatroban or lepirodin. Okay, so these are simply alternatives for heparin, but they work the same way as heparin, but they're not heparin. And I won't repeat thrombolytics. You already know what thrombolytics are. And before we forget, so teaching again, patients taking any anticoagulant, what do you teach them? Bleeding precautions. All right, so here are your bleeding precautions. No alcohol. Okay, so that's a long, is this a chart? Chart 2610. Okay, let's continue with we know the medical management already, and we know the procedure, okay, why we start with heparin first. So let's continue. If a patient is definitely unstable, the blood clots are, let's say, too many, too big, we can't do anticoagulants, so either we give them thrombolytic therapy, or if the clot's really big, surgery. So not all hospitals can do embolectomy. Only the large ones, let's say New York Presbyterian can do that. Bellevue can do that. So that's what will be done if the clots are really huge. For those who have recurrent PE despite therapeutic anticoagulation, the patient is a candidate for a filter. They'll put in an IVC filter. It's not 100% guaranteed though. It has a 2% failure rate, because what if the clot forms above the heart? Because in inferior vena cava, this will only catch blood clots coming from where? From the GI tract and the lower parts of the body, right? Because it's in the inferior vena cava. You may ask, well, why don't we put another one in the superior vena cava? Well, there's no such thing. Okay, they haven't figured out how to put a filter there yet. So therefore, that's the other problem. So what if the clot forms above the superior vena cava? So there's a 2% failure rate. But you still have 98%. I'll take that, right?
Couldn't there be still obstruction in the inferior vena cava with the clots backing up against the filter?
No, the filter looks like this. It looks like the spokes of an umbrella without the cloth, like that. So that's a filter, and this is the blood clot, right? So it's just a bunch of sticks, and it will filter and catch a clot, and then the clot, of course, will be destroyed by the body. At least it won't, obstruct anything. Did I answer your question? Are you sure?
Yes.
Because I think I lost my.
No, you got it. Because I was saying, like, I was wondering, like, wouldn't it just stay there for days that once it's caught, the body would destroy?
Oh yeah, so it'll at least it won't move. It'll just stay there, and then the body will dissolve that slowly. Get a question?
Yeah, you said like for the IVC, the clots are coming from the GI and burns. Yeah.
Well, where does all the blood come from that's entering the IVs, the inferior vena cava? Yeah, from your esophagus all the way down to your toes. I won't do because there are complications also related to the IVC filter. They can break and become emboli themselves. That's why you have lawsuits. Okay, so for stable PE, meaning no hemodynamic problems, meaning these are the low risk and the submassive PE, our mainstay for treatment is simply anticoagulation. How long the doctor decides that, because they can tell based on the patient's risk factors, meaning what does the patient have? Why did they throw a PE in the first place? So they'll determine how long they'll be on anticoagulants. Typically, if their risk is low, they'll just be on anticoagulants for 6 months. But if they have a higher risk, maybe a few years, or even higher risk, the patient would be on anticoagulants for life. Yes.
Question about the anticoagulants you take home, or you said that since they're based on weight at that point, they have a drastic weight change.
Which one? Low molecular weight?
Low molecular. For those patients that are like heart failure that have like diuretics, is that weight change enough to be worried about?
No, because we're talking 10 pounds or more.
Okay.
So it's not likely to, to be like that.
What did you say about taking the long term for life?
It's all the duration of anticoagulation all depends on the patient's risk factors.
Okay.
Meaning, why did they throw a clot in the first place? If that risk is likely to persist forever, how long will they need anticoagulants? Forever. So what are those forever things? Let's say, give me examples. Heart failure, is that short term? It's long term. AFib, that's long term, right? So you get what I'm saying?
Yeah.
So how long they'll be on anticoagulants really depends. What are why did you get a clot in the first place? So let's say your risk was because you were smoking and taking oral contraceptive pills. Is that lifelong? No, because you can stop smoking and you can you can use another birth control method. So is your risk forever? So how long do you think you'll be on anticoagulants? Probably up to 6 months. And then after that, no, I'm no longer smoking. Okay, fine, you can get off. The rest of these are symptomatic management. So if the patient did go into cardiac arrest, we already finished MI and shock, and then you guys know CPR, you know BLS. Pain management will be usually morphine, because this is a cardio issue as well, and then giving oxygen therapy. Anxiety management if needed, you give them benzodiazepines, and then again, complications. Okay, complications of PE usually is on the cardiovascular system. Any questions? Very good. Come back at 2:35.